I'm going to try and do this topic, hopefully some justice. So I was tasked with speaking about motor disorders in KAND, and much of what I'm going to talk about is, I think, influenced by my experience overall, taking care of children with a variety of different motor problems, but also very much by what we've learned from all of you. So thank you for that. These are my disclosures. And before I go into the talk, I want to acknowledge the fact that everything that I'm going to present today is made possible by courageous patients and families. I'm going to share some videos with permission. So a big thank you to all of you in the audience. So in the next 25 minutes, I'm going to hope and cover 4 areas. First, I'll talk about hereditary spastic paraplegia, which is a condition related to KAND, to KIF1A related disorder. I'll then show you a little snapshot of the data that we've gathered since we've been involved in this study, in the KOALA study over the last 12 months. So I'll talk about the motor symptoms and the spectrum that we've seen. I'll then talk a little bit about the approach to symptomatic treatment of spasticity. And I picked spasticity because it's the most common motor problem in KAND. And then hopefully we'll have some time for questions and discussion. Just because I've met many of you, but not all of you, I just want to briefly introduce our program. Here at Boston Children's, we have a specialized movement disorder program. We take care of children and young adults with all types of movement disorders. We work very closely with our Cerebral Palsy Center. We have a special expertise in something called deep brain stimulation, which is relevant to a disease called dystonia. And we conduct basic and translational research, and we've been very fortunate to work with the KOALA study over the last year. So I'll start with hereditary spastic paraplegia, and I'll try to build an arc between hereditary spastic paraplegia and KIF1A related disorder. I'll first introduce what hereditary spastic paraplegia is. This is a condition that is clinically and molecularly heterogeneous. We now understand that it's actually a group of over 90 different genetic disorders. They all have one thing in common. They all present with progressive lower limb weakness and spasticity. I'm showing here a patient of mine, with permission, showing a typical gait for someone who has what we call spastic paraparesis, so weakness and spasticity in the lower extremities. And hereditary spastic paraplegia, like much of neurology, is something that was described in the 19th century. You see the first publications here in the German and French literature in the late 19th century. But it wasn't until genetic testing became available that we learned it's actually a group of 90 different monogenic diseases. And KIF1A was described as a form of hereditary spastic paraplegia, or I guess a part of the spectrum of KIF1A related disorder was described as a hereditary spastic paraplegia, specifically type 30. If you take all forms of HSP together, you have a combined prevalence of about 5 in 100,000. So it's a rare disease, but I think it's vastly underdiagnosed, and I'll show you why in the next couple of slides. And then historically, we distinguish between pure and complex forms of HSP, and most of the childhood onset forms are complex, which means they have additional symptoms beyond weakness and spasticity. So I want to show you why I think hereditary spastic paraplegia and KIF1A related disorder by extension are more common than we currently think. And many of you will know this, but I think there's a good body of work now, a good body of evidence that shows that the yield of genetic testing in children who have a clinical diagnosis of cerebral palsy is somewhere around 30%. So if you take 100 children who were given a diagnosis of cerebral palsy, 30 actually have a genetic diagnosis. This is a recent meta-analysis, sort of a summary of all the studies published in the last couple of years that finds that, I think, unequivocally. And when you then look more carefully, I just picked randomly 4 studies, including one done here in Boston. What are the genes that are actually being discovered? You learn that 25% have hereditary spastic paraplegia. And I'll point out this last paper, which is a systematic review by my colleague, Srivastava, who looked at this more carefully and found that the second and third most common gene were the most common autosomal dominant forms of HSP. These are SPAS and ATL1. But KIF1A was in the top 10. So again, this is, I think, going to the points that were talked about this morning. We need better access to genetic testing because I think a lot of children are still being diagnosed with other conditions, including cerebral palsy, before genetic testing is pursued. So about 5 years ago, we decided to start working on hereditary spastic paraplegia. This was something very much inspired by families we met in clinic. And we recognized very much like this community that a natural history study was needed to better understand the symptoms and to get us ready for clinical trials. So we launched a single center natural history study at first. That's the study that you see here. And over the last 5 years, we've had the privilege of meeting over 600 families with different forms of hereditary spastic paraplegia. I'm playing these videos without commenting on them much, but just to say that there's a huge spectrum when it comes to severity and symptoms, and that's not unlike what we see in KIF1A related disorder, ranging from very young children affected by very severe symptoms to young adults affected by relatively mild symptoms. So just to show the complexity that we see, and I think that has prepared us well for asking questions that this community is asking. How do you use natural history data to support a clinical trial? How do you design a natural history study that can capture this complexity? The other thing that we learned is that it's very hard to do this kind of work at one single site. It requires huge efforts. So we've been very fortunate to receive funding to create a network of centers across the US. This went live about a year and a half ago, and now we have 11 sites that take care of patients with HSP and conduct research across the age span, so both pediatric and adult patients. And I think this is something that I think this community can also benefit from in the future. Now, this gave us a great start, and I think we've learned a lot. We've made contributions in many different areas. I won't go through this in detail. We learned that about 30%, despite our best efforts, do not receive a genetic diagnosis, and we've launched some research programs around that question. And we occasionally find conditions that mimic cerebral palsy, mimic hereditary spastic paraplegia, but are actually already treatable conditions, so those are always important to keep in mind. So this was a great, I think, for us it was a great experience, and I think it grew very quickly. But despite, or beyond, I should say, describing the problems, we really want to get to therapy. So I look at this natural history study very much as a platform for novel molecular mechanism-based treatments. And I would argue hereditary spastic paraplegia, and KIF1A included, is an ideal situation for that because we have a clear phenotype that is shared between different diseases, but we have all molecular mechanisms present. So you can think of platform trials where we use the same approach regardless of what therapy is being tested for a given molecular mechanism. Okay, I won't go into too much detail about this part because I think that was covered in prior talks, but just to say that we know that rare disease drug development is very, very complicated. And our team is only contributing a very, very small part to this long and complicated process. And we've decided that we're in a unique position to address two challenges. One, clinical trial readiness, which we define as a state of having validated clinical research tools and natural history data sufficient enough for the efficient design of clinical trials. And that takes a lot of key stakeholders, but we're happy to do our part. And then developing molecular mechanism-based treatments or disease-modifying therapies based on a molecular mechanism. So before I go to KIF1A related disorder, I wanted to share an example of a disorder I started working on when I was a trainee a couple of years ago. And this was a chance encounter. I met a little patient in clinic who happened to be number 9 to be diagnosed with this rare form of hereditary spastic paraplegia. And we recognized that there was an opportunity here. I had known about this protein in the pathway because my PhD studied the same pathway in the context of Parkinson's disease. So we started working on a group of disorders called adaptive protein complex 4 associated hereditary spastic paraplegia. Not something you need to remember, but I think you'll see some parallels to KIF1A related disorders. So this is a group of rare or ultra rare diseases, actually 4, that are genetic. They're recessive disorders, so it's a little bit different from KIF1A related disorder. And they all have one thing in common. They encode the same protein complex. And not surprisingly, these 4 disorders have the same clinical phenotype. Many of these symptoms are shared with KIF1A related disorder. You see some of my very first patients here, and you recognize that although they have mutations in different genes, they present very similarly. All of these children present with low muscle tone initially, and then delayed motor milestones, which is typically what brings families to see a neurologist. What we've learned, and I think this is very much a lesson in rare disease research in general, is that the first step is to get a sufficiently powered cohort together for a cross-section analysis, because with rare diseases you don't always know what the symptoms are, what the spectrum of symptoms are. So we've been very fortunate to collect, going from 9 patients to 150 patients within 2 years. And we found that progressive spasticity is the hallmark feature of this disease. And I think that's shared with many in the KIF1A group as well. So over the years, we've been able to really learn a lot about this disease. And I won't go into details, but sufficient to say that we learned that this is not just a progressive neurological condition, which it was described as. I think you've heard this theme before. All of these disorders, including KIF1A-related disorder, I think of as a neurodevelopmental and a progressive neurological disease. And that's important to recognize because the tools that we use to study and measure change over time, which is critical for knowing if an intervention is working, will have to be different depending on where we are in that spectrum. So that's just, I think, an important lesson that I think we all need to recognize. Okay. Not to belabor this too much, but we've had the opportunity to follow about 300 patients longitudinally. You see the distribution here. And one thing that we've learned is, I think, similar to what you're learning, is that there's a huge spectrum when it comes to severity. So I'll show you here the more typical presentation. Most children with AP4-related HSP develop progressive lower extremity spasticity between the ages of 2 and 5. This makes walking more difficult. Weakness is also similarly part of the motor disability. Between the ages of 5 and 10, we typically see the need to support with a walker most often or other walking aids. And then by age 10, the majority of children unfortunately require a wheelchair for ambulation. So that's just to show the complexity. And we can talk about the many lessons we can learn from different forms of HSP that have many things in common with KAND. But I wanted to really show you what we've learned in the last year. We've been invited by Dr. Chung to join this study and to look at motor symptoms. And I'm showing you some preliminary data, and this is all cross-sectional. So we don't have longitudinal data in this analysis. So we've had the opportunity between July of last year and July of this year to meet 48 children and young adults with molecularly confirmed KIF1A-related disorder. You see about half were female, about half were male. The majority came from the United States, but we had a few international families visit us or come to this conference. And the mean age at assessment was 9 years, although again there was a spectrum including young adult patients. What we've learned is very similar to what we've seen in other childhood onset forms of hereditary spastic paraplegia, which is that the symptoms actually start very early. So on average, the first symptoms are reported at 9 months of age. Global developmental delay is very common, 96%, 46 out of 48 children showed global developmental delay, and you see the motor milestones listed here. This is all retrospective, of course, but you see that milestones are reached at a later age, which is often a reason for presentation to a neurologist or pediatric neurologist. And we also learned that about 70% acquire the ability to walk assisted, 60% unassisted, but at a significantly delayed age, at about 2 years on average. This, of course, doesn't capture the entire spectrum and the complexity, so I think I want to show you a few videos just to illustrate the wide spectrum, which ranges between what we call global motor function classification scale 1 to 2 to 3 to 4 and to 5, which again just illustrates that there's a broad range and we need to have tools that can measure motor symptoms in all of these situations. The other thing I wanted to mention, I'll come to this on the next slide as well, is that this is of course not just spasticity. This is a much more complex picture. I think in KIF1A related disorder, more than in other forms of hereditary spastic paraplegia or other motor disorders in the same category, see a lot of impairment due to neuropathy as well as weakness. So that's, I think, something that is adding to the complexity, and we have to acknowledge both in how we conduct the assessments, but also in clinical care. Just to give you a quick overview here, this is the distribution of GMFCS levels, showing that there's different levels of motor disability. This is, of course, not controlled for age. Spasticity is common. 70% showed spasticity in the lower extremities. Other movement disorders, however, like dystonia, are exceedingly rare. We didn't find a single patient with dystonia. We found ataxia in 10 out of 48 patients, tremor, as we've talked about earlier. And then looking at the scores for spasticity and the distribution, you clearly see a pattern where you have more spasticity in the distal lower extremities and distal legs, meaning in the ankles, and less so in the hips, at the level of the knees and hips, which I think is explained by the function of the protein. And then you see the developmental support and therapy listed here as well. But I think what distinguishes KIF1A-related disorder from other forms of HSP, particularly pure forms of HSP, is the fact that the motor impairment and the motor problems are really a function of many different symptoms. And I think we've touched upon this already, but just to say, I think there are clear motor symptoms, which include weakness and spasticity, both what we call cerebellar ataxia, which is a problem of coordination due to a problem in a part of the brain that coordinates movement, as well as what we call sensory ataxia, which is more of a problem of the information not traveling back fast enough to the brain, which makes it very, very complex to tease out what is the main contributing symptom. But then we also have other comorbidities, other comorbid symptoms, including, as you know, dyspraxia, cognitive challenges, behavioral challenges, and visual impairment. And then I think, a clinical lesson is also, I think, in puberty, there's often a lot of weight gain, which also impacts mobility overall. So I want to spend the last couple of minutes giving you just a very, very crude overview of how we approach the symptom of spasticity, acknowledging that in every patient we go through the different contributing symptoms and make a best decision based on risks and benefits. But just to focus on our general framework for a few minutes, when we see a child with a movement disorder, a motor impairment, we basically look at three things first. We take into account the underlying movement disorder, we take into account the associated morbidities, we take into account the etiology, and we ask ourselves, what's the impact of the symptom on function and quality of life? What is the natural history of the disease? And what are the risk-benefit ratios of my intervention? And our interventions at this time fall into four categories. For some disorders, there are specific disease-specific therapies, either truly disease-modifying therapies or therapies that are superior to others for a specific disease. That's unfortunately not true in KIF1A-related disorder, at least for now. The majority of what we do is symptomatic treatment. We treat the symptoms, and this includes both medications, and I'll review some of them with you in a moment, as well as using procedures such as botulinum toxin or Botox injections or phenol injections, intrathecal baclofen, I'll touch upon a little bit, and then surgical procedures, including selective dorsal rhizotomy and others. Much of what we recommend is also in the domain of prevention and developmental supports, so physical therapy, occupational therapy, equipment, orthopedic surgery in certain instances, and then the developmental and psychiatric or psychological support. Wanted to touch upon a little bit on the pharmacotherapy of spasticity. This is, of course, a general sort of approach, and is something we tailor to every individual patient. But wanted to mention a couple of things that we observe. So, for the treatment of spasticity, again, we weigh the pros and cons. We weigh the risks and benefits. And in terms of pharmacotherapy, we actually don't have that many different agents available. Some of our first-line agents are listed here. That includes baclofen, it includes benzodiazepines such as clonazepam or diazepam, includes clonidine, gabapentin can be helpful, especially if there's pain, and then other agents for more severe spasticity such as dantrolene. Most often we start with Botox because it has the best risk-benefit ratio. It doesn't have a lot of risks and it has potential for benefit, whereas most of the medications, the systemic medications, have a risk, substantial risk for side effects, especially in vulnerable populations. So again, this is something that we can talk about in the Q&A session, but this is what we have for symptomatic treatment. In some cases, we recommend surgical treatment. This includes essentially three different procedures. The first is something called selective dorsal rhizotomy, which is a procedure that is reducing muscle tone, is reducing spasticity by removing a part of the circuitry that controls muscle tone at the level of the spinal cord. It's a surgery that is irreversible, and it has a very narrow indication, in my opinion, and especially in a progressive disease like KIF1A related disorder. I think there's very few instances where we would recommend that. There's something that we're employing more and more called a combined ventral and dorsal rhizotomy, which is a procedure that is looking to alleviate substantial spasticity. So when you have spasticity to a point where it leads to orthopedic complications, pain, in someone who's not reliant on their muscle tone, on their spasticity to stand or to do transitions, it's something that we recommend more and more because it can prevent a lot of orthopedic complications and it can prevent a lot of pain. And then lastly, what we've had for many years is intrathecal baclofen, which is a treatment delivered directly to the spinal cord through a catheter. That can be helpful in a similar way. It can reduce pain, discomfort, orthopedic complications, but carries a certain risk because it's an implanted device. So all of these are very nuanced discussions that we have in clinic because we want to choose, again, interventions that have a favorable risk-benefit profile. So with this very broad overview, I'll conclude, and I hope I was able to show you that childhood onset hereditary spastic paraplegia, like KIF1A related disorder, is both a neurodevelopmental and a progressive neurological disease. Having broad access to genetic testing and having a natural history study is a prerequisite to establishing clinical trial readiness. KIF1A related disorder presents with a range of motor symptoms, as you know, including spasticity, which is the most common. And then these longitudinal natural history studies, including the QUADA study, really support to serve both counseling, symptomatic treatment choices, making more informed choices, and in the future, hopefully also interventional trials. So thank you very much for listening. I want to point out the members of my team who did all the assessments, who met with all of you over the year, including at this conference. And thank you very much for having us. It's been a great pleasure. So thank you.
All right, we'll open up for questions. Oh, and we can go to, there we go. We'll start with this one from Slido. What percentage of the KAND community seems to benefit from Botox? How many times to try increasing doses if first or second treatment attempt doesn't help? And maybe this is just a more general question about how do you think about Botox dosing? Yeah, very good. It's a great question and certainly one that we often discuss. I can't answer the first part. So what percentage of patients benefit from Botox? That really depends on where the spasticity is, what the functional limitation is, what muscles we target. So there's no sort of one-size-fits-all approach. One thing that we can say, though, is that we often don't see the full benefits of Botox after the first round of injections. So our general counseling is always that you have to have 2 or 3 rounds of injections to really know if Botox is helpful. The other thing that we counsel is try to use something called a goal attainment scale, which means that we sit down with the family, we ask them, what are you trying to achieve? What would you call a success? Because I think this can be very different between different families. But in general, I would say you have to give it at least 2 or 3 rounds because during the first round of Botox, the clinician will take a best guess as to which muscles are most relevant, which dose is relevant. The second time around, you're informed by the first round, and the third time you usually have the right muscles and the right dose. So I would not give up after first round of injections. Got a question over here.
So when you what do you where can you buy like canes for people that need more help in the home instead of walkers? How can you buy that? Can you buy that on Amazon?
Yeah.
Or do you have to go in the stores?
Yeah, great question. So I think, I'll broaden the question and say, how do you get the right equipment? And I would say that is often something that is driven by the physical therapist or the physiatrist who can recommend the type of equipment that is best for your case. And then there's different avenues for obtaining that equipment, including dedicated shops. Some of it may be available online, but in general, we work with the physical therapist or the physiatrist on that question.
I'll take another question from Slido quick. Can you talk about the relationship between pain and motor function? We obviously have neuropathy in KAND, but also when you do have spastic movement and these changes, especially as you're gaining weight, there's also a pain element just to moving around, right?
Yeah, I think that's a very good question, actually. And I would say I think we see pain arising from three different mechanisms, if you will. I think the first is we often see that individuals who have significant lower extremity spasticity, that they get muscle cramps, particularly at night, or lower back pain, particularly at night. I think that's directly related to muscle tone, and that's where interventions targeting muscle tone or gabapentin are often helpful. The second is there are kids, and I always worry about kids who are nonverbal, who have orthopedic complications and pain related to that. So hip subluxation, misalignment of joints that can really, I think, lead to a lot of pain and is often under-recognized. And then the third part, and this is more specific for KIF1A, is the neuropathy. And I would say as a general approach, we often use, if there is significant pain, we often use gabapentin or similar agents as a first approach.
We're going over here.
Hi, how do you measure spasticity? We've been using baclofen forever. Botox didn't work.
Yeah.
Honestly, I don't see that the baclofen is helping at all. And also, some of the symptoms that you had associated are things that our daughter experiences, and I'm wondering if we should substitute something else. But how do you measure to begin with?
Yeah, it's a great question. So I think there's two ways to measure the impact of spasticity. One is you actually measure the muscle tone, and we have different scales for that. I went over one very quickly called the modified Ashworth scale, and similar other scales. That actually just looks at muscle tone. How much tone is there at a given moment? Acknowledging that this can fluctuate. It can be different in the morning versus night. It can be different in clinic versus at home. I think what's more important is to think about what are the functional limitations that come from tone. What is most difficult because your legs are tight? Is it changing? Is it transitions? Is it sleeping at night? I think focusing on what is most impacted by the tone is a better way of looking at, is my intervention working? If the answer is the baclofen isn't doing much, I think it's something to discuss. And sometimes we think the baclofen is not doing anything, but then when we take it away, we actually learn it was doing something. So it's a nuanced discussion, but I would encourage everybody to review their medications on a regular basis, because there's no need to take baclofen or other medications if it's not providing one of those functional benefits that are important to you.
I think you kind of answered the question I had.
Go for it. You have a nicer voice than I do.
When it comes to Botox injections for children who are mostly wheelchair bound, I'm just curious, how do you measure success? And how do you know if it's actually benefiting the child when they're not verbally telling you, yes, it feels better?
Yeah.
Do you have any recommendations?
Yeah, I think it partly comes back to the same concept. So we would ask you what are the situations where the muscle tone is really getting in the way of taking care of your child. And many families will say it's when we try to get dressed, when we do transitions. So that's one part. The other part of using Botox or medications is to prevent complications. What are the complications of prolonged spasticity? It's something called contractures, meaning that the tendons and the joints, they change over time, and there's a fixed posture that arises from that, and that can lead to problems with your joints over time. So part of it, recommending these types of treatments, is trying to prevent that or push that out. But the first question is more important. What are the things that you are seeing in your day-to-day life that are impacted by the high muscle tone? And I would look at that.
Thank you for this. I'm wondering if you could explain, and forgive me if you already did, the difference in benefit between oral baclofen and the baclofen pump.
Yeah, it's a great question. So oral baclofen as a medication is often limited by side effects. Main side effect being sedation. It makes you tired. It can also lower your muscle tone to the point where it's actually detrimental. By giving the medication not systemically by mouth, but through a catheter at the level of the spinal cord, one can use much higher doses. So the effect is much higher. The dose is much lower. That is the main difference. The baclofen pumps conventionally are placed at a level of the lower spinal cord. So intrathecal baclofen mainly affects symptoms lower than that level, so meaning legs mostly. We sometimes see some benefits in the arms, but it's mostly a treatment for the legs. And those are the main differences. And I'll just say that the pumps, they carry a risk too, so I think that's important to remember.
Thank you.
Hi, I'm Hans Christinger. Fantastic presentation and discussion. Thank you. I want to go back to what you said about the underdiagnosis. And did I hear you right that maybe 30% of cerebral palsy has a genetic underlying cause? Do you have an estimate for KIF1A, what the percentage would be?
It's a great question. So you're right, 30% is what we find when we take all the studies together. And these are studies that had different inclusion criteria. Yeah. For KIF1A, it's very hard to estimate that. I would ask the room, how many of your children had a diagnosis of cerebral palsy before molecular testing, before genetic testing, and a correct diagnosis? So I don't have a good sense of that. Anecdotally, I can tell you for HSP, the majority of our patients have had a diagnosis of CP first, because that's what people in the community think about. That's what a community pediatrician thinks about, because it's much, much more common than these genetic diseases. But I think what we're also seeing on a positive note is that because we have genetic testing available much earlier, we're seeing patients being correctly diagnosed at a much younger age. That's the best answer I can give you. I don't have a number, but that would be an interesting question, I think, for the community.
I think we're going to wrap up and move on to the next question. I want to let anybody who submitted questions on Slido know that we are taking these questions down. We will look into them and we'll provide whatever insights that we can. But I want to thank Dr. Darius for giving us this run through and his insights.
Thank you. Thank you.